Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of today's presentation, we will open the floor for audio questions. At that time, instructions will be given as to the procedure to follow if you would like to ask an audio question. Also, please note that during today's presentation, we'll be presenting two polls. In order for your vote to count during these polls, you'll need to click the appropriate answer within the slide window it appears. It is now my pleasure to introduce today's first presenter, Ms. Anna Wojcik.
Thank you, David, and welcome, everyone. Welcome to the April On the Cusp Stop Clotting ICU National Content Webinar. Today we'll be talking about urine culture practices in the ICU, antibiotic stewardship, some practical ICU tools, and using the results from the Safety Culture Survey. Just a few housekeeping items before we get started. A brief overview of the platform in addition to the announcements David made. You'll notice that we've added back the attendee section based on some feedback from last month's call. State leads will also be receiving a more comprehensive list of the attendees after the webinar. A note that due to the size of this call, our operator might need to pull some of the lines after the webinar has already begun. So if that happens to your line, please, it'll only take a few moments and you'll be joined back into the webinar audio as soon as possible. Slides can be downloaded in the bottom right-hand corner in the materials section. They're also available on the website, and they'll always be available on the website prior to the webinar. And then you can use the chat box on the bottom to post any questions or have any discussion with other participants, but note that we'll also have that dedicated Q&A time at the end of the webinar. And then finally, I know that there's been some issues with the webinar calendar appointment and the correct information being sent out and included in that appointment. So following today's webinar, Kathy Drury will actually be canceling that whole webinar series, and she'll be sending out individual calendar appointments for all of the remaining monthly webinars. Just to note that the dial-in number and the webinar link, that dial-in number, the passcode, and the webinar link will not change. So the same link and number that you use today will be the same link that you use for all of the remaining content webinars in the project. Okay, and with that, we're ready to get started. This is just a reminder about completing the webinar evaluation after the webinar is completed. If you have to jump off early, please be sure to click on this link and just fill out whatever portion was relevant to what you heard. We do ask that everyone who is listening to the webinar fills out a separate evaluation. So if you have 3 to 4 people in the room, please, if you could all complete the webinar evaluation, it really helps us in tailoring this content. Today's presenters will be Dr. Mohammed Faqih. He's the Medical Director of Infection Prevention and Control at St. John Hospital and Medical Center, and the Professor of Medicine at Wayne State University School of Medicine in Detroit, Michigan. We also have Pat Poza, our resident CUSP expert, who's also the System Performance Improvement Leader at St. Joseph Mercy Hospital. And then we'll have a team from Carolinas Medical Center presenting today, starting with Dr. William Miles, who's the Director of Surgical Critical Care and the Clinical Professor of Surgery at the University of North Carolina, Chapel Hill, Charlotte campus. And he has 2 of his ICU teams with him today, Misty Wheeler, Lacey Spangler, and Julia Rotelsky. So we're really excited to have these great presenters here for you today. And without further ado, we'll get started. Dr. Faqih?
Thank you very much, Anna. Hello, everyone. So I'm going to talk a little bit about culturing stewardship or appropriate culturing in the ICU mostly. I'll start with a case, a 45-year-old gentleman who is an active drug user. He's admitted to the hospital with a fever of 103. He's confused. He has respiratory distress. He gets intubated and admitted to the ICU, and they do a chest X-ray on him, and it shows multiple pulmonary emboli. They do blood cultures. It's growing MRSA. He continues to have fever, and by day 3, because he's febrile, his temperature was 101.8. His blood cultures are still positive for gram-positive cocci. If you're the clinician seeing that patient, would you do a urine culture on that patient at that point? So this is 3 days into his admission to the ICU, treated for MRSA. Please go ahead.
Okay, Dr. Fike, I think our votes are slowing down.
Okay, so we push and pull. Is that correct? Well, it's about, what I can say, we have about 70% who say no urine cultures, and that's the correct answer. So we have a source, you have a source of Staph aureus bacteremia, drug user. This patient is likely to have a right-sided endocarditis with septic emboli to the lungs, and it'll take a few days to clear that bacteremia, and you'd know he still has an infection in the blood. So there's no reason in this situation to have a urine culture done on that patient. I'm going to skip to the next slide. The majority did very well. Oops. Yeah, I'll take care of it, please. Okay, so 73-year-old gentleman with prostatic enlargement admitted to the hospital with abdominal discomfort. They examined the patient. At that point, he had normal vital signs, and his white cell count is normal. Bladder scan shows 1,200. It shows a very large urinary bladder. They catheterize him. He has 1,200 milliliters of urine drained. His abdominal pain improves with the catheterization. He did okay overnight, but then spiked fever the next day. His blood pressure was 100 systolic, and he was a little bit tachycardic with a heart rate of 110. Would you do a urine culture or not? Oh, this was a very easy question, it seems. So the vast majority is doing great. So the reason why I put these two cases is that it's extremely important for clinical decision making to be part of your ordering of any culture. So the first case, you have very clearly a patient who has an infection related to drug use. He has endocarditis, and there's a source for that infection. The second case, there's also more of a likelihood that the urinary source was the reason for his fevers. So that would be a pertinent thing to do to get a urine culture done. What I'm going to try to do within this presentation is I'm going to describe to you how often bacteriuria happens in a catheterized patient. I'm going to try to talk to you more about, if you have a catheter and what is the odds to get bacteria at day 1, day 2, and so on. Most of these studies were old studies. It seems people can't hear me well. Let me see here. Sorry about that. So most of these studies are old studies. The main study was by Garibaldi in 1982. At that point, what they did is they looked at patients prospectively and looked at bacteriuria over time. So at insertion, they found about 9% of the patients having bacteriuria. And then they looked at those that had a catheter for more than 24 hours. And these patients developed bacteriuria in about 15% of the time. And the risk was about 3 to 5% per day. Bacteriuria happens through two different routes. One is an extraluminal ascent, so it's the outside of the catheter, and the organisms will ascend through the extraluminal area to go into the bladder, and then bacteria, will reach the bladder, or through the urinary system, where the urinary system is contaminated. So whether we open the urinary system or break-in technique happens. So what will happen at that time? It's an intraluminal ascent. Another study, a French study by Kleck, looked at 12 ICUs where they did weekly urine cultures if the patient had symptoms. And they defined COTI as more than 1,000 colony-forming units per milliliter. Because of their definition and because of how often they did these cultures, they had a very high bacteriuria rate. They had about 13 per thousand catheter days. And the median time to COTI in that study was 11 days. But when they looked at those that had longer length of stay in the ICU versus those that had shorter length of stay, they found out that those with longer length of stay had much more CAUTI than those that had shorter length of stay. So the mean length of stay of those that had a catheter-associated UTI were 28 days versus those without 7 days. Now, you'd think even 7 days is a long period of time being in the ICU. Common inappropriate triggers for urine cultures in patients with urinary catheters include the urine color, the smell of the urine, or consistency of the urine, and also the issue with pyuria. And you're going to see my next few slides, and you're going to be very probably surprised about what I'm going to say. I'm going to try, hopefully, to show you some studies that clearly show that the pyuria was not very, strongly related to infection, and the positive predictive value of pyuria not being that great. So this is a study was done at my facility, and we looked at resident physicians and nurses, and triggers for cultures in catheterized patients, typically urine cultures. So one trigger for a urine culture would be like foul-smelling urine. We asked the residents, if you have, so different scenarios, different case scenarios. Patient with foul-smelling urine, would you do a urine culture? And resident would say in 71% yes. Nurses, in fact, in 95% of the time, yes. Cloudy urine, pretty much the same thing. Very high percentage saying yes to doing urine cultures. Sediments in the urine, half of the residents said yes to do a urine culture. Nurses said yes in 85% of the time. Darker urine, so let's say someone is dehydrated, more than a third of residents said yes, and the nurses, half of them said yes. A chronic urinary catheter on admission, about 40% of residents said yes, we'll do urine culture. This is asymptomatically just because of that reason, and the nurses about 75%. Chronic urinary catheters will end up having 100% bacteriuria. So there is no benefit of doing a urine culture in them unless there's symptoms. We looked at pyuria, and the higher the white cells in the urine, the more likely they will do a urine culture. And this is not surprising because when we're taught about UTI, we're taught about urinary tract infection in non-catheterized patients, and I think we extrapolate to the catheterized patient. So this is the IDSA guidelines, the Infectious Disease Society of America guidelines, and it clearly states that pyuria does not help differentiate between asymptomatic bacteriuria and catheter-associated UTI. And also states that pyuria and bacteria in the urine does not equate CAUTI. Another study by Tambaya and Mackey in 2000 in the Archives of Internal Medicine, they had about 800 patients with newly inserted catheters, and what they did prospective culturing of these patients, and also they looked at pyuria at the same time. They defined the bacteriuria as more than 1,000 colony-forming units per milliliter, and they found out that women had more bacteriuria than men. They had about 3 times more bacteriuria than men, which is not surprising because of the short urethra and the easier ascent of the organism into the bladder. So the first day of infection means having bacteria in the urine, they looked at how many white cells they had. And those that had gram-negative organisms in the urine, they had much more white cells than those that had staph or enterococci or yeast. And as you see here, 34 white cells for gram-negatives versus 8 for staph and versus 9 for yeast. And those that had the catheter the first day, so these were called the uninfected patients, had an average of 5 white cells in their urine through the UA. And as you see here, the highest value, so looking at all these numbers per patient, the highest value of white cells, you see there's less in those that are uninfected, but you see there's a huge standard deviation of 100 here. And again, those that have gram-negative bacilli tend to have more white cells in the urine. Now, so what is the positive predictive value of having pyuria? So they looked at those that had more than 10 white cells in their urine. and looked at the positive predictive value of having bacteria in the urine, and it was 0.36, so about a third. So if you have 100 that had a positive UA, it's going to be 36 of them will have bacteria in the urine. And this is not symptomatic. This is just saying that they have bacteria. So what the Infectious Disease Society of America guidelines state is that the absence of pyuria in an symptomatic patient suggests the diagnosis other than catheter-associated UTI. So if you do a UA in a patient you're suspecting a urinary tract infection with a catheter, then if the urine analysis does not have any white cells, it's going to help you. But if it has white cells, it's not going to give you the answer whether there's an infection or not. As far as the odor or the color, the guidelines state that in a catheterized patient, the presence or absence of odorous or cloudy urine alone should not be used to differentiate catheter-associated asymptomatic bacteriuria from catheter-associated UTI. And it's not an indication for urine culture or antimicrobial therapy. What about screening urine cultures? This has been something very common after CMS said we're not going to pay for the diagnosis of catheter-associated UTI in the hospital. So a lot of hospitals started screening on admission, and they had it into standing orders or reflex orders. And there are certain hospitals that have either fever packs or fever triggers, and they do urine cultures or sputum cultures or blood cultures without evaluation, just based on a temperature. And these are quite dangerous because what may happen is that we may be overutilizing resources and getting a lot of false positives. And when you have a positive culture, whether it's a sputum or your urine, physicians, clinicians tend to treat a number or a culture, and this can adversely affect our patients. And one simple bad outcome can happen is Clostridium difficile. So this is a pre-printed order on, from a hospital that I've visited, and as you see here, they have for newly inserted Foley catheters, obtain a urinalysis at the time for the Foley catheter insertion, do culture and sensitivity if UA is abnormal. First thing is I would not do a urinalysis unless this urinalysis is going to help me take care of the patient. If the patient is asymptomatic, there's no reason for me to do a urinalysis on that patient. So I think one item that's very important is to look at your standing orders and make sure that these are updated and you don't have these triggers that can give you a major headache as far as global care in your hospital, and not one practitioner's care, but it becomes a process through all the hospital. So how to reduce unnecessary urine cultures, evaluate the current processes for obtaining urine cultures. As I said, avoid automatic triggers or screening cultures with no appropriate indications. Evaluate practice patterns, so avoid pan culturing. I think there has to be mindfulness every single time we see a patient. What is the most likely source of that fever? Is it infectious versus non-infectious? And if it is infectious, let's figure out whether the urine is more likely to be a source versus, let's say, pneumonia or a line infection or an intra-abdominal process. And provide the education on when it is appropriate to do a urine culture. And that's, I think, a very tough part. The fourth item that we suggest is to have periodic audits on urine culture use in the ICU to look for trends. One thing that can be very forgotten is that residents change with time. So you have a teaching hospital, you get residents every month, and this can affect. Some people don't know what is the process regarding working up a fever, and you need to re-educate them and engage them. The last one is promote appropriate urine catheter use, so reducing unnecessary urine catheters. This is a summation of what I talked to you about, basically mindfulness as far as when you do culturing, and the appropriate urine culture use should be a part of an evaluation of sepsis without a clear source. So if you have a clear source, then you don't need to do his urine. COTI is often a diagnosis by exclusion. And the other thing, it can be based on local findings suggestive of gastro-associated UTI, such as pelvic discomfort or flank pain. Unfortunately, this is very uncommon, especially in the ICU patients or in patients that still have the catheter. And prior to urologic surgeries, this is an indication you do urine culture screening if you're going for urologic surgery. But other surgeries, it's not indicated. Early pregnancy is another indication for urinary cultures, rarely seen in the ICU, however. Make sure that your physicians are aware of the appropriate indications. Point out the risk of indiscriminate urine culture use. We've seen many cases where you had intra-abdominal catastrophes with Clostridium difficile because of unnecessary antibiotics. And address the local culture and the practice of clinicians, and avoid ordering cultures without clinical assessment. This is our hospital, and I want to share with you, we had SIRs that were very high. This is 50 adult ICU beds, 3 units. One is a surgical intensive care unit with neurotrauma, one is a medical intensive care unit, and one is a cardiac unit. And as you see here in 2013, we had SIRs up to 2, and then we worked on the devices and making sure that insertion is appropriate and maintenance, but we also looked at culturing stewardship, and we've been having great results since then, and these results continue. So we have an SIR of less than 0.5 right now. We're an 800-bed hospital. Thank you very much for your time. Dr. Miles?
Yes. Thank you, Dr. Fakih. Hope everyone can hear me. We're going to talk today about antibiotic stewardship. I want to thank Dr. Passaretti, one of our infectious disease preventionists at our institution, who provided me with some of the presentation and slides from her perspective. First of all, I also would like to say I'll be happy to add any more information to those institutions and ICUs that may not have started an antibiotic stewardship program in your ICU. There are many different ways to begin that process. Obviously, I wanted to add a disclosure slide. There's nothing to disclose. I do not have any consultant contracts with any organizations at this time. Let's talk about antibiotic stewardship in the ICU. The main points, before we actually get into the actual process of antibiotic stewardship, the appropriate components of understanding why we have gotten to this point is that resistance to antibiotics exists in nature before medicine actually discovers or uses them. What we are seeing in our society is that with the overprescription of antibiotics for many small maladies, as well as majority of antibiotics being in our food sources, as well as many antibiotics, when not used, dumped in the sewer system, bacteria in our society are actually exposed to a lot of antibiotic pressures and therefore have progressed to resistance many times even before they have gotten into a hospital system or in the management of patients. Some of the key points I feel that are important for antimicrobial treatment that we all ought to follow, especially if we all can look at the 30,000-foot view at our institutions. You can see, as Dr. Fakih mentioned, many times in a teaching institution, you have residents, you have fellows, you have attendings, all with variable ways they treat an infection and use antibiotics. But in treatment considerations for antibiotics, we really should be timely in starting them. I'll provide a slide that looks at delay in starting them actually increases mortality. We need to be appropriate, meaning cover the broad spectrum of pathogens for the potential infection you have. Understand pharmacokinetics. If you don't have a very obese patient versus not, versus a certain organ dysfunction, you need to provide adequate dosing and intervals. And above all, standardization and narrowing and discontinuation of antibiotics based on clinical data, clinical response of the patient, as well as I hope many institutions have their own ICU or hospital-based antibiograms, which do show what flora and bacteria in their institutions may be more susceptible versus other institutions for the same infections. This is a slide looking from Dr. Coliff and company that actually looked at the importance of initial and appropriate antibiotic therapy. And as you can see from all-cause mortality versus infection-related mortality, if you have inadequate antimicrobial treatment, which included timing, dose, pharmacokinetics, etc., you have a higher mortality versus if you have adequate antimicrobial treatment. And this is one of across all critically ill infections, but it does show the importance of appropriate initial antibiotic therapy. Another reason why we need to get to this point of appropriate antibiotic stewardship is that the number of antibiotics being produced by big pharma companies are really being reduced. In the 1980s, there were 16 new antibiotics released. By the early 2000s, only 5, and in the last 4 years of 2008 to 2012, only 1 new antibiotic was developed. So we have to be better stewards with the antibiotics and how we prescribe them, because not many of them are going to be produced in the future. What is antimicrobial stewardship? Most of us know, but it is basically a systematic approach to optimize clinical outcomes while minimizing a consequence of the antibiotic use, such as toxicity, selection of resistance, selection of virulent organisms, including Clostridium difficile resistance, which we are seeing in this country. You need any antibiotic stewardship process, and there are many types of antimicrobial stewardship practices and policies across the country. Every unit really should have some process for it, but it should be combined with infection control practices to limit emergence and transmission. It is and does reduce healthcare costs without impacting care, and it is all about patient safety. Just to show you a group of organizations that have mandated or recommended and suggested hospitals have an antibiotic stewardship program. Infectious Disease Society of America, the Joint Commission has done that. Medicare in California made it a mandate. Centers for Disease Control, Physician Leadership Forum, including other organizations such as the American Thoracic Society, American College of Chest Physicians, and the Society of Critical Care Medicine. So many organizations have recommended antibiotic stewardship programs at ICUs. And the goals of antibiotic stewardship on this next slide, really it's a circular component of combating emergent resistance. It is somewhat about controlling costs in this new value-based healthcare that we have, as well as improving clinical outcomes. We all feel that appropriate treatment of an infection is important, but it should be somewhat standardized based on a geographical, institutional location, the flora, the resistance patterns, and the type of infection, as well as the clinical response. If you're treating a catheter-related urinary tract infection on a elderly patient who's also a transplant patient, it's going to be different than someone who is a trauma patient who may be younger. Some of the stewardship strategies that are very important, whether you have a very basic type of antibiotic stewardship or if you have a more strong antibiotic stewardship, including antibiotic resistance practices or prescription practices. There are several strategies that can be used, from patient evaluation as well as the education guidelines, formulary restrictions with the choice of antimicrobial, which I don't totally believe in formulary restrictions, but I do believe in formulary guidance with the help of our pharmacy departments. PharmDs are very important, which I'll get to in a slide in our ICUs. Computer-assisted strategies in most of the electronic medical records now, and when we do prescription ordering, if there are shortages, if there are suggestions by the antibiotic stewardship committees, prescription ordering can be altered. Many of us in busy ICUs may not realize some of the ordering practices and standards based on the infection. So that's another avenue. and in the actual dispensing of antimicrobial processes. All these, with review and feedback, should be utilized for an antimicrobial stewardship policy. Some of the economic considerations for antibiotic stewardship, obviously it looks at antibiotic use restriction and cost, but that should not be the only focus. Much of what we need to look at isn't just acquisition of antibiotics. It's a small part of the treatment. It's actually the cost from the hospital length of stay, total healthcare cost, and above all, patients' quality and return to functional life above all. That quality of life is very important in looking at appropriate management of infections. This is just an example of how prescribing antibiotics should be standardized from an empiric antibiotic process based on the disease or infection and your ICU's antibiogram. The biogram is very important, and most institutions have them for the hospital. If you're lucky enough to be practicing in an institution that actually breaks down the individual ICU's antibiogram based on the specialty that you may have more in your ICU, I think that is very helpful. Day 3 should be considered narrowing or de-escalation or discontinuing antibiotics based on culture results, whether it's an infection versus leukocytosis, what is the actual clinical picture, is the patient improving, etc. And as I mentioned before, base it on the antibiogram of the individual unit or institution. This is where I think it is important to understand that using your infection preventionist, utilizing your PharmD if you're lucky enough to have one in your ICU, it's very helpful. In our institution, we actually utilize our PharmD as the first step in antibiotic stewardship, helping us as in the multi-professional element of the ICU. The PharmD is a professional that really guides us in what the antibiogram may be seeing in the last quarter, knowing what the dosing and above all the pharmacokinetics based on the patient size, based on the patient's disease processes, and it's been very big help in the first phase. Second phase is when we come with the infection preventionist and the antibiotic stewards that actually look at 48 hours to see if certain antibiotics might be able to be tailored, if they're functional, and can give guidance. We don't yet have a truly antibiotic restriction process, but it does help having these professions. And above all, it does prevent multi-drug resistant organisms. This is an example of treating using antibiotics in urinary tract infections, above all catheter-associated UTIs. And I'm not going to rehash what Dr. Faki had mentioned, but this came from Johns Hopkins guidelines from 2015 as an example. And above all, it shows the importance of culture stewardship as well as antibiotic stewardship. There are some practices, and I've seen it in dealing with some surgical colleagues, that they do follow-up urine cultures or another urinalysis for serial response and to see if the patient's getting better. I don't think, based on all the evidence-based medicine, that should be done. The follow-up urine cultures or urinalysis should not be acquired routinely to monitor response to therapy. And the prevalence of asymptomatic bacteriuria is high, as Dr. Faki had mentioned, but especially in certain patient populations. Looking at the duration of treatment, even though for catheter-associated UTI has not been that well studied, but there are a lot of standards out there, we really should look at standardizing practice based on the antibiograms, your own infections in your ICUs. And as I'll mention this now, the many times I see in my institution with new residents and fellows and attendings who have looked at what I call football scores. They want to keep it at 7 days, 14 days, or even had one surgeon treating someone for 21 days with a catheter-associated UTI. Those variable practices need to stop, and that's the advantage of having a process and programs for antibiotic stewardship. Above all, also for treatment notes for UTI, remove the catheter whenever possible, as we all are part of this collaborative to look at those policies and processes, because prevention is the key to get to not even need treatment for UTI. Prophylactic prophylactic antibiotics at the time of catheter removal or replacement are not recommended due to low incidence of complications, and catheter irrigation should not be used routinely. As I mentioned, antibiotic stewardship must coincide with infection control and prevention, optimal management of the urinary catheters, which we've all talked about, as well as prevention control practices. This came from the CDC. And I list all these as the wheels turn. Antibiotic stewardship is in the middle, but all of these key cogs of the wheel, pharmacy providers, microlab, infection control, patients, and any QA process, all make antibiotic stewardship flow at an institution. And I'm doing the 30,000-foot view of multi-drug resistant organisms. We are all trying to prevent the rise of these and the carbapenem-resistant Enterobacteriaceae, the MRSA, the C. diff, colitis, all these, we've seen a higher incidence of these. Antibiotic stewardship and urinary catheter removal protocols are essential tools for prevention of these MDROs. And as to show antibiotic stewardship and its practical implementation in an ICU, this came in a study that basically looked at antimicrobial stewardship programs' impact and looking at in one aspect of it, but across the pre-antibiotic stewardship program to the post-period. Looking at the very last line, it did affect across different departments, but above all, the total hospital cost did improve with no change in hospital mortality. But it does show practical implementation of antibiotic stewardship. And in addition, there was another study that just was released today in Sweden looking at antibiotic stewardship practice in 5 months in an institution, and it showed improvement in morbidity, mortality, and reduction of antibiotic use. I wanted to bring in two of our intensive care units' work in implementing antibiotic stewardship and appropriate urinary culturing. I want to introduce Misty Wheeler and Lacey Spangler from our surgical trauma ICU, and Julia Rutelsky, who is my co-state lead in North Carolina for our SCCM cohort, and who is the CNS for the neurosurgical ICU. Lacey?
Yes, you can go on to the next slide. So we're a 29-bed multi-specialty neurological and neurosurgical unit, as well as my unit in the surgical trauma ICU. We're also a 29-bed multi-specialty unit that cares for transplant patients, immunotherapy patients, as well as obviously the surgical and trauma population. We have 874 licensed beds. We are the level 1 trauma center, and we are the largest teaching hospital in North Carolina. Next slide. So this is a graph showing you where we are with our CAUTI reduction over 2014 and 2015. For time's sake, I'm going to start with our urine culture initiative, where the arrow is in January, between December and January of 2015. Before that, our highest actual raw number of CAUTIs was in August of 2014, where we instituted our CAUTI bundle, much like we've spent most of these webinars talking about. But we're going to focus on our urine culture initiative. So in November of 2014, we saw another spike of CAUTIs after we had started our CAUTI bundle, and that's where we began our proper culturing initiative. We did intense education with both our providers and our nurses to culture to source versus pan culture that we've heard spoken about today. Specifically with the nurses, we focused on sending the UA first, then if that came back positive, then sending a urine culture. A specific challenge that we faced in the surgical trauma ICU is that since we are a teaching facility, we have residents that rotate monthly in our unit who weren't aware of our culture of sending a urinalysis before sending a urine culture. So we did a lot of work empowering the bedside nurse to help educate the residents on our proper culturing and sending a UA prior to culture. We did house-wide education to send urine cultures in a preservative tube and not in a specimen cup, and we do audits of that as well. We also learned that it's very important that the correct collection source was entered into the electronic medical record. So, for example, if it was a clean catch specimen versus an indwelling catheter specimen. So we've done a lot of work in auditing around to make sure that that source was correct. And as you can see from our graph, especially after our proper culturing initiative, we have had 0 CAUTIs for over 3 months. To be exact, we've gone 104 days without a CAUTI. Also impressive is our reduction in our urine cultures. We compared our quarter 1 2014 and our quarter 1 2015 urine cultures, and we have had a 63% reduction in our urine cultures. So in quarter 1 of 2014, we sent 166 urine cultures versus quarter 1 of 2015, we have only sent 61 urine cultures. As far as sustainability, our IPs collaborated with our IS department, and they created a daily report of urine cultures that were ordered and or sent. So in our department, we reviewed this report daily, and we also complete a chart review of every urine culture that was ordered and or sent, and we acknowledge staff that appropriately cultured or drew UAs and did not culture. We acknowledge them in our daily huddle. Our nurse manager acknowledges them in front of their peers. So I'll turn it over to Julia now.
Well, and I will just add, along with STICU, we followed the same initiatives, and we also saw a reduction in the amount of cultures and the amount of compared to the amount of CAUTIs. Going back real fast to specimen processing, I think one of our big learns from this was noticing or realizing that when the order was put into the electronic medical record, Lacey mentioned the source. If the source was a clean catch urine versus from a urinary catheter, it is processed differently in our lab. And the numbers, they look at the numbers a little bit different. So that was an aha moment for nursing and for some of our providers. We did not realize that the specimens were run a different way for depending on how the source was put in. So a lot of our education really focused on that. And we also saw huge reductions in our medical intensive care unit as well as the Dixon Heart unit. Let's see. And currently we are going to work with our lab. This is support with our infection prevention department and the medical director of the lab to do urinalysis and then reflex testing for urine cultures. Let's see, next slide. Okay, and I'm going to turn it back over to Dr. Miles.
Thank you, Julia. As you can see, the use of antibiotic stewardship as well as culture stewardship can make a difference in practical implementation in ICU. Some of the tools that were mentioned, the audits were such as Dr. Faki had mentioned. All these are very important in achieving results in your intensive care unit. I can tell you in our surgical trauma and neurosurgical ICUs at our institution, we had a very high rate of CAUTIs. This remarkable reduction has been the team effort and as well as this collaborative in order to adopt the principles and policies that are important in antibiotic stewardship and CAUTI reduction. In conclusion, from my portion, providers do need better tools on how to initiate and terminate antibiotics, and I think the stewardship teams are just one step to regulate antibiotic prescribing. Importance of standardizing your practice of antibiotic use and the use of institutional antibiograms are important, really to stop the antimicrobials treatment based on clinical picture, and obviously don't use variable football scores to decide length of treatment. Antibiotic stewardship and proper culture, and they do go hand in hand and are synergy with the teamwork and that team effort in following the CAUTI policies and guidelines. Good results can be achieved, as we've mentioned in our ICUs. Pat, turning it over to Pat Posa.
Okay. Hi. So great work, and I echo the results we instituted at my organization, the stopping culturing, pan-culturing, and we're seeing significant drops in our rate as well. But I'm going to turn over and talk to you about the Comprehensive Unit Safety Program, our CUSP, and we're going to talk about safety culture, interpreting the results. And the importance of culture, we're talking a lot about culture today. I'm going to talk a little bit about changing that culture to support the technical interventions that you heard today. So what is culture? It represents that set of shared attitudes, values, goals, and practices and behaviors that make one unit distinct from the next. And in our program here, aren't we truly trying to influence behaviors and practices? And so we're trying to influence the culture of the unit. Culture is usually unspoken, implicit, taken for granted, and often largely invisible. And it's important when you think of culture that you measure it and think of it and try and impact it at a unit level, because culture can be different in different units. Our surgical ICU culture is different than our medical ICU culture, as well as even within a unit, the day shift culture is often different than the night shift culture. So, and it's because of the people and the attitudes, values, goals, and practices that they bring. The Institute of Medicine shares with us that the biggest challenge in moving towards a safer health system is changing that culture. And one important change that needs to happen is to change from a culture of blaming individuals for errors to one in which errors are treated not as personal failures, but as opportunities to improve the system and prevent harm. That doesn't negate holding people accountable to performing established practices and guidelines. So there's a fine balance between that. So we strive for, and the Comprehensive Unit Safety Program will help us get to a positive culture of safety. And that's really a culture where we recognize that errors will happen and we proactively seek to identify latent threats and do something about them. So we don't wait for the errors. We're always constantly vigilant to finding errors, and people talk about errors and potential errors, near misses, so that we can view them as opportunities to make things better, establish better, more standardized processes, etc. We know that chaos and less predictability results in worse safety. So if we can improve the predictability, resulting in less chaos, we will have better safety. And how we do that is through standardization, checklists, familiarity, good orientations, etc. So as part of the patient safety movement and as part of the CUSP program, as you're putting this in place in your unit, and I know a lot of hospitals measure their safety culture. We are actually not administering a safety culture survey during this collaborative because of the short time, but it's still important to, as an organization, you should be measuring your safety culture annually or every 18 months, and then when you measure that safety culture, you need to then do something about the results. And why should you measure unit culture? Because you need to determine how the bedside staff are feeling related to communication, errors, teamwork, and safety. So it helps you diagnose and assess your current state of culture, identify your strengths, and then also your areas for opportunity to improve. It allows you to examine trends over time and measure and evaluate the impact of different strategies that you're implementing to improve the culture. So CUSP is one of those interventions, and we'll talk about it more specifically in how it relates to improving safety culture. So it's important that when you administer the survey that you get a good response rate. You want to at least get 60% of your staff to respond in order for really those results to be generalizable and really reflective of your staff. And once you get those results, you need to organize and share them with your staff and begin to problem solve and create action plans with the staff to where there are areas of opportunity where you can improve. So this assessment data is likely to point to many different areas of culture that can be improved, and there are many different potential actions. You want to start small, do incremental change, change one process at a time. And remember, you're not going to be able to solve and improve your safety culture with just doing one thing. You'll need to do multiple things. There really isn't one silver bullet. So when you get your survey back, you need to drill down to understanding what it says. One of the domains that you'll be looking at are questions related to teamwork. And often what pulls your scores down, where people don't feel like there's good teamwork, is questions related to difficulty speaking up when I'm concerned about an error, breakdown in interdisciplinary care coordination, how conflicts get resolved related to patients, etc., and I don't feel comfortable answering questions. Also, you might find that the safety-related questions get pulled down because there's lack of trust that if I report an error that it's not going to go into my personnel file, and lack of engagement. So we need to change the unit culture, and as we heard earlier today, the work on changing the entire safety culture will assist you as you're working on changing the culture related to CAUTI. So by improving the overall culture in your unit, one of the first steps is ensuring that everyone believes that any harm is not acceptable. And we know CAUTI is a harm to a patient, and that should be considered unacceptable. And if this is present, if this belief is present, you're going to see that on some of the categories from the culture survey. So non-punitive response to error. If people believe and feel comfortable talking about errors and that they don't feel they're going to get a punitive response, then your culture is changing to allow those kind of discussions to be able to problem solve and make things safer. And we want to ensure, and as you heard today, we want to avoid the practices of pan-culturing, and the focus on a positive safety culture is to also ensure that we're mindfully choosing interventions. So don't do things because that's how we've always done it. Do things mindfully that you have a reason. I'm not going to pan-culture, but I'm going to, as Dr. Miles presented or Dr. Fakih presented early on, the patient that clearly did not have a urinary source for that infection, you don't need to get a urine culture. Having interdisciplinary discussions of the risk versus benefit of starting antibiotics as part of your antibiotic stewardship program. Again, having interdisciplinary discussion means that you have to have a culture where everyone can speak up and their input is valued. And so by working on your culture, you'll be able to support these types of conversations. So what do you do with the results? And I know we only have a couple minutes. Teamwork climate is usually the consensus of the frontline caregivers related to collaboration. And so these are common questions that get answered, and they get answered not as positively. In a clinical area, it's difficult to speak up. Disagreements are not resolved appropriately, and physicians and nurses work well together. So if you don't have high positive scores on these, then you have a teamwork problem. So as you get your culture results, and this is your safety culture, and most people are using the AHRQ HSOPs, you want to review the results with your staff, and there's a zillion questions. I think there's 65 or something. So you're not going to be able to focus on everything. So one way to do it is to pick 5 areas where you saw good, really positive results and celebrate those, and ask the staff, why did you score that positively, or get some thoughts behind it, but really recognize that you have some good pockets of excellence. And then pick 5 areas where you have the most opportunity. So I'm going to walk through an example. For example, here's a positive under the section of supervisor and manager expectations. On this particular survey, they got a 76% had strongly agreed that considered staff suggestions for improving patient safety. in teamwork, people support each other in this unit. When lots of work needs to get done quickly, we work together as a team. People treat each other with respect. So highlighting these good things that are happening. And then you can focus on the least positives, and you can look at the domains or the specific questions. And so here there was a low response to staff feel free to question a decision or action of others. And so there has to be some work to help with that. Interdisciplinary rounds. So one of the Comprehensive Unit Safety Program's communication and teamwork tools of interdisciplinary rounds will assist you in improving with that. Feedback and communication about errors. Doing learning from defects is going to help improve that. Non-punitive response to errors. Again, using that staff safety assessment tool as well as using the learning from defect tool is going to help the staff realize that we want to hear what are the issues and the problems and safety concerns so that we can solve them. So if you have a teamwork problem, then here are some tools to use to help improve that teamwork. And we'll be talking at the next content call, we'll talk about some teamwork tools. So if you have poor staffing levels or you feel information's lost at change of shift, then doing morning or shift briefings. Interdisciplinary patient management issues, then institute interdisciplinary rounds with daily goals. Role clarity conflict, shadowing exercises, difficulty speaking up. You institute some standard language, SBAR or other critical language. If it's safety, then ensure that you're educating people on the science of safety. If their staff isn't feeling engaged in safety and quality, doing the learning from defects will be very, very helpful. And executive partnerships will help them feel engaged and get the appropriate resources. So I know that was a quick, brief overview, but it's just what I want you to walk away from is that it's important to change your culture if you're to a positive safety culture where people talk about errors and you can have good conversations. In order for all these technical interventions to stop CAUTI to work, you have to also be promoting and working on creating a positive safety culture. Okay.
Terrific. Thank you so much, Pat. Again, thank you to all of our presenters. I know that we're almost at the top of the hour. Going to send the evaluation to everyone now. If you have to leave right at 3 o'clock, please be sure to fill out that evaluation. I think we'll take one or two questions in the Q&A, but I do encourage everyone, if you have questions, we will probably not be able to get to all of them. So I would ask that you post your question in the chat box, and we'll ask our presenters to answer any of the questions we can't get to in the Q&A. Okay, so we'll take one or two questions. David, can you start that process for us?
Absolutely. Ladies and gentlemen, if you'd like to ask an audio question, please press *1 on your touch-tone phones now. Again, if you'd like to ask an audio question, please press *1. Ms. Wojcik, at this time we have no audio questions.
Great. Well, in lieu of questions now, I again encourage you to post questions there. You can email any questions you have directly to me as well. Thank you, everyone, for participating in today's webinar. We'll see you all again next month on May 13th for our next content webinar. The recording and all of the details from this webinar will be posted on our website by early next week. Thank you again to everyone.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us today.